we're a minute past the hour mark, so we should go ahead and get started. So,
Sure.
hi everybody. Welcome to Department of Medicine Grand Rounds. For those of you who don't know me, I'm Adrian. I am one of the inpatient chief medical residents here at the University of Washington. We have the Dave Park lecture. So, to introduce both the lecture and our speaker today, I would like to invite Dr. Masa Narita. Um, Professor in the Division of Pulmonary Critical Care and Sleep Medicine, as well as the TB Disease Control Officer in the Department of Public Health here in Seattle and King County. So, Dr. Narita, take it away.
Oh, thank you so much, Adrian. Welcome to the Dave Park Memorial Lecture. Dr. David Park, a beloved pulmonary and critical care physician at the Harborview, passed away in 2016 at the age of 54 after a courageous 6-year battle with brain cancer. Dave was raised on a family farm in Vermont and attended the University of Vermont for medical school, where he met and fell in love with Julie, his future wife. Together, they moved to Seattle for their residency. Dave in medicine and Julie in pediatrics. Dave's leadership qualities were distinct early on. He was selected as the chief resident at the Harborview, as seen in this photo on the left. He trained in pulmonary and critical care medicine at the UW and later joined the faculty in the division. Dave's background in New England cultivated a straightforward and candid communication style, yet always with a twinkle in his eye, as this center photo captures. He possessed an abundance of common sense, which he brought to the practice of medicine. Deeply loved by his patients, he thoughtfully aligned his recommendations with their priorities. A gifted teacher, Dave received numerous awards for his dedication to medical education. He was a valued colleague, mentor, and friend. Dave was particularly passionate about tuberculosis, non-tuberculous mycobacteria, NTM, and medical education. This passion inspired him to found the Furland Northwest TB Center, which supports this memorial lecture. Contributions to the centers are greatly accepted through the UW Medicine website. These three areas of David's passion also guide the memorial lectures, which brings me to today's speaker. It's my pleasure to introduce our speaker, Dr. Kevin Winthrop. Dr. Winthrop is a distinguished professor of public health, infectious diseases, and ophthalmology at the OHSU. Previously, he served as an infectious disease epidemiologist with the CDC Division of TB Elimination. Dr. Winthrop has co-authored over 400 publications. His research focuses on the epidemiology and clinical aspects of TB, NTM, and other infections associated with the rheumatology and biologic immunosuppressive therapies. Clinically, he offers regional consultations for mycobacterial diseases and other chronic chest infections, and serves as the medical consultant to the Oregon Public Health TB Control Program. His Center for Infectious Disease Studies coordinates many cohort studies and clinical trials, in which he serves as the primary or senior investigator. Dr. Winthrop founded the NTM Research Consortium and its associated clinical trial network, which facilitates clinical trials for patients with NTM. He is a dedicated member of OHSU graduate faculty, and he mentors public health students, medical students, and physicians in postgraduate training. Without further ado, now Kevin, please. Thank you.
Thank you very much, Masa. Hopefully you guys can hear me and see me, see my slides here. First of all, it's a real pleasure to be invited to speak in this memorial lecture. Dave was a fantastic guy, and I'm sure everyone else misses him dearly, just like myself. And he was a friend and a colleague, and just a fun person to work with. And it was really sorry to see him go a few years ago. So I think the fact that you guys established this lecture is fantastic in his name, and it's a real tribute to his career and just him as a person. He was a great person. So anyway, so it's a pleasure to be speaking with him in my mind today. So thank you for having me. And Masa, it's great to be able to talk about Mycobacterium. So the title of my lecture is Mycobacterium 2025. I wanted to give a couple quick TB updates and then talk about non-tuberculous Mycobacterium. And then leave some time for questions. So we'll go with that and try to make it fun, at least. I mean, when you're talking about Mycobacterium, it should be fun. These are my disclosures between some industry support for NTM work and then some federal grants, which hopefully we'll keep going. We'll see how that goes. So I'll start the talk with this slide. This is from Japan. This is Japan Epi. I could show you this slide from all over the world, actually. Most places where TB rates, with the exception of the last year or two, this post-COVID bump where we've seen some increase in the US and a few other places, primarily overall over time, over the last few decades, of course, TB rates are going down, which is the top two curves of this figure, and NTM rates are going up. And in fact, the more you look for NTM, the more you find it, and the incidence is rising worldwide. So my work here and really in the US, we're kind of dominated by NTM. And there's been such a paucity of therapeutic options for NTM, and it's been hard to diagnose. And I'm going to get into all that in a bit. There's a lot of catch-up work to do in NTM, whereas TB, we have lots of drugs, we have new drugs, we have new regimens in development, and some are now recommended, which I wanted to highlight here. But really, NTM has kind of played this catch-up to TB for years, and we're not caught up. So I'll kind of highlight where we are with NTM and what we're doing to try to catch up. But first, I do want to mention a couple really, I think, important new pieces of guidance from CDC and from IDSA, ATS, et cetera. So this was the new practice guideline. A lot of you have probably seen it the last couple months it came out. And there's a couple things to highlight here. One is really at the bottom. There's some regimens now that are short course regimens for multi-drug resistant TB or specifically rifampin resistant TB. And then, of course, a shorter 4-month regimen now that we're starting to use in pan susceptible TB. So this is BPALM, this is bedaquiline, pretomanid, linezolid, and moxifloxacin. This has been looked at in a number of clinical trials. I'm just highlighting one of them here. This is in rifampin resistance. And remember, MDR-TB is defined as rifampin and INH resistance. Most of these people probably had MDR-TB, but the inclusion criteria were at least rifampin resistance. And the bottom line is the primary outcome measure was unfavorable status after a certain amount of weeks. And if I remember right, I think it was after 72 weeks. But the bottom line was this was a collection of death, TB recurrence, TB relapse, or failure, or loss to follow-up. And the bottom line is that people who did this short course BPALM regimen did much better. Their relapse rate or their unfavorable rate was 24% as compared to 53% in the standard care group, which is a collection of drugs given over usually 12 to 18 months. So this is a regimen that has shown efficacy in six months or 24 weeks. It substantially shortens our treatment route to helping people with rifampin resistance or MDR-TB. And this is something now we are starting to use in the US when someone can't use rifampin or they have a resistant isolate. The other thing I want to highlight among the TB regimens is this. If I can see my screen. Going back, this is my big problem with the BPALM, and this is my big problem with the shorter course regimens. It's the use of linezolid. This was something we published about 10 years ago in ERJ, and these were patients being treated with linezolid primarily for NTM disease. But you can see the onset of cytopenias and the onset of peripheral neuropathy occurs within a couple months, and it's pretty substantial. Even after like 3 or 4 months, you see about 50% of people have dose-limiting problems, primarily peripheral neuropathy, and then cytopenia was a close second. The bottom line is we did this because I was having all sorts of problems keeping people on linezolid. So we really tried to better understand in observational fashion, how long people can take it for. And so I typically reserve linezolid for my back pocket when I'm treating difficult to treat NTM infections, which I'll get to, because I know people aren't going to tolerate it very long. I think TB is a little different than NTM. TB patients tend to tolerate drugs to a different extent because they're different types of patients. But the bottom line is, I think there are some options that will help linezolid tolerance with some of these short course regimens. And this was a real-world study that was published fairly recently, showing, with 68 or 70 patients, they showed almost everyone did well with this linezolid containing regimen. And this was B-PAL. This didn't include the moxifloxacin, which has its own tolerability issues, which I'll talk about later, or maybe we could talk about in the question period. But the bottom line is a lot of these people reverted, and I just have a red circle here, to 600 milligrams, not once daily, but 3 times a week. And theoretically, probably 3 times a week therapy is just as beneficial as daily. The bottom line is don't use 1,200 daily. 600 daily you can start with, but with therapeutic drug monitoring, and/or, to be honest, if you don't have access to that, just moving to a TIW regimen is probably the way to go in terms of handling the linezolid. So stay tuned with this. I think if you're in a health department, you're using this regimen, again, you're going to try to do therapeutic drug monitoring around linezolid, which will help guide you here. But the bottom line is, in the real world, this looks fairly effective, despite the tolerability issues with linezolid. And the last thing to say about TB is the new 4 months short course regimen, which I just was asking Moss if they're using in Washington. It sounds like you've got a couple dozen cases you've treated so far. In Oregon, we're just starting. It's a little more expensive of a regimen. In fact, it's twice the cost of regular RIPE, which is rifampin, INH, PZA, and ethambutol. So at the bottom, this is the usual regimen for your typical pan-susceptible TB case, or at least, INH, rifampin, PZA susceptible TB case. And then, the comparative regimens were the 4-month regimen above here, and then in the middle, and they substituted rifampin. They substituted rifapentine for rifampin, which is a long-acting form of rifampin, essentially. And then the upper regimen substituted moxifloxacin for the ethambutol. And what these investigators were able to show was at least the upper regimen that contained rifampin and moxifloxacin for 4 months was equivalent to that typical 6-month RIPE regimen. And that was this red circle down below here. These are the survival curves. There's a cumulative percentage with unfavorable outcome, which was low across the board, and it was similar or non-inferior with this group. So the 4-month regimen above here, the rifapentine, moxi, INH, and PZA, this is now possible to use. And I think, as Moss and I were just talking before we came on, this and the last regimen really has to do with patient selection. You want to try to focus this in patients who are, younger, have fewer comorbidities, have fewer drug-drug interactions, things like that. There's a lot of things to think about in terms of who's going to tolerate these things better. Some people don't tolerate fluoroquinolones, of course, long-term due to, muscle or muscle issues, arthralgias, tendinopathy, et cetera. So these are things you have to monitor and see how you do going along. My experience is Levaquin maybe has less of these problems with moxifloxacin, but again, that's just something you have to troubleshoot as you go along. So again, these regimens probably won't be for everyone. I suspect there'll be people you start on the 4-month treatment and then they blow out of it because they can't tolerate the moxi, for example, and you might have to revert to the regular RIPE. But for suffice to say, for a large majority of patients, you can at least envision starting this 4-month regimen if they're eligible. So that being said, that's TB. I think those are important updates. I think we'll start using the short course regimens more and more. So now let's talk about non-tuberculous mycobacterium. If you're really old on this broadcast, which you're probably not, you would call these MOTT, Mycobacterium other than tuberculosis, MOTT. At some point, this term drifted to atypical tuberculosis or atypical mycobacterium. Some people still call these organisms that. The preferred term now is non-tuberculous mycobacterium or NTM. Some people want to rename them EMs or environmental mycobacterium because these are environmental bugs. They're in the soil, they're in your water system at home in Seattle and elsewhere, they're in rivers, etc. They basically live where biofilm occurs. I mean, they love biofilm, they make biofilm, they embed themselves in the biofilm of the airway or the pipes of your water system at home, and they live with gram-negative bugs, etc. I always like to talk about this because it's kind of fun. It's my favorite bug. It was named Mycobacterium jacuzzii. It was linked to a surgical outbreak of skin infections post-breast augmentation. This was actually in Israel. The public health authorities there did this great little investigation. They found 15 cases. They linked them to all to one surgeon. And they went to this guy's house and they cultured his hair, face, eyebrows, nose, ears, growing basically all his hairy surfaces. And this is a picture down below here. This is actually Sasquatch. That's Bigfoot. That's kind of how I imagine the surgeon looking. I don't know if that's true, but that it brought to mind Sasquatch as I was reading this report. Anyway, they found this bug on the surgeon in all these areas and also in his home jacuzzi, and they matched up identically with the isolates from the patient. So somehow, well, and in fact, this was thought to be Mycobacterium smegmatis, which is another rapid growing mycobacterium, which was first found in someone's urethra, I think in 1947, hence the name. But it turned out it was slightly different than smegmatis, and they named it jacuzzii. But somehow this surgeon was going home every night after a hard day in the OR, soaking in the jacuzzi and then oozing this stuff onto his patients the next day. I'm not sure how that was happening, but that's what caused the outbreak. And again, there's all sorts of fun names, and often we have like over 200 species of Mycobacterium now that are NTM. And I'll tell you, only about 10 or 12 of them seem to be pathogenic or ones that we see causing problems. But there's lots of things like this that are out there. This was a photo we published in the Clinical Infectious Disease Journal a few years ago. It was entitled Happy Buddha, question mark. And this Buddha appeared happy, but you can see these little red dots on the Buddha. These were not measles. The Buddha didn't have measles, but they were little tiny dots of infection. This was Mycobacterium coloniae. It turned out this was the index case in a nationwide tattoo ink outbreak. And the tattoo ink was made in LA in some factory, and somehow tap water was brought into the tattoo ink manufacturing process, and it was contaminated with M. colonia. And so, this Buddha developed all these little measles, and we treated this person or we treated her tattoo for 3 months, and the Buddha became much happier. His skin cleared, and etc. I will say that you will see some of these infections sporadically from tattoo artists who will, in an effort to make gray, they'll take black ink and they'll cut it or mix it with tap water to make it less dark. And so sometimes you see these infections starting in the grayish aspects of a tattoo. So there you have it. So someone asked me a few years ago, actually 10 years ago, well, geez, is NTM like TB? I mean, we don't really know. How does it manifest? What proportion of cases are extra-pulmonary or pulmonary, etc. So for TB, about 75% of TB is pulmonary. Well, it turns out for NTM, it's the same. It's about 77%, 75%. And the biggest players are Mycobacterium avium intracellulare, that complex, or MAC, we call it, MAI or MAC, and then Mycobacterium abscessus kind of takes up the rest of it. So about 85, 90% of NTM in the US is MAC. The rest is abscessus, and then there's a few stragglers with Colonia fortuitum, lentiflavum, Kinzasia, a few of these, a few percent for each of those, roughly, depending on where you are in the U.S. Most pulmonary disease is due to MAC, again, about 85, 90%. Extrapulmonary, it's still also more likely MAC, 55, 60%, but the rapid growers like abscessus fortuitum, and colonii particularly, they are more common in the extrapulmonary setting. So this was a friend of mine. Anyway, I show this because this is if you didn't shower this morning, well, that's good. You didn't expose yourself to NTM. But if you did shower, like this friend of mine is showering, she's bathing herself with MAC and Fortunatum and all these other bugs I just mentioned. So there's really two main disease types. Now, most people aren't at risk for this, right? You take showers every day, you don't develop these infections, but from a pulmonary NTM standpoint, I'll go over some risk factors and whatnot. But in terms of the epidemiology and the clinical presentation, there's kind of two types. There's the middle to older age female, and then there's kind of the middle to older age male. However, I will tell you that these are blended together. And they're really two distinct types in terms of what the underlying issue is. One issue is being really skinny and having bronchiectasis. And this is an example of a CT scan from a very thin elderly woman. You can see she has very little soft tissue, and she's got classic right middle lobe bronchiectasis here on the right. And then you see some stuff happening as well in the lingula. But these areas become progressively worse over time. This is very classic pulmonary MAC presentation. Sometimes the MAC causes the bronchiectasis, or in other cases, patients have bronchiectasis for other reasons, either genetic or post-infectious or other reasons, and then they breathe in the MAC, and the MAC seeds the area, and then they develop pulmonary MAC that way. So it's a chicken or an egg thing. It can be causative, but it can also be an advantageous organism just taking advantage of that problem in the first place. This is a patient you would think has TB, this right upper lobe cavity. In fact, this patient did come to me as a TB, quote unquote, suspect. It turned out she had MAC. This is that emphysematous smoker form of the disease where we more typically see cavitary disease. Kind of perversely, the people who've smoked and destroyed their lungs, they're actually easier to cure. Why? Probably because they don't have this intense biofilm associated with their bronchiectatic airways. They just don't really have bronchiectasis, or they have very little of it. It's really the emphysema. You can clean these areas out. That being said, if you don't get at them soon enough and they've already developed cavities or large cavities, it can be very difficult to cure because you just can't clean the cavity out. So if you can get them when they're young, quote unquote, or, so to speak, like this patient, I mean, we cured her cavity closed up. She hasn't had recurrence for many, many years. So again, two main types: nodular bronchiectatic, thin people, and then there's a smoker-related disease. The epi is what I told you before. It's increasing everywhere. This was a study we did 4 years ago, one of the more recent epidemiologic studies in the US using population-based data, both commercial claims data as well as Medicare data. And you can see the rates over time are increasing in both men and women. And overall, they're higher in women than they are men. And that's true of pretty much everywhere in the country. So the rates are, of course, much higher in older individuals, which is this triangle up here, up to 18 per 100,000, and people over 65. And people in the general population, the rate's more like 5.5 or 6 per 100,000. So it's a rate that's 2, 3, 5, 10 times fold higher than TB, depending on where you live in the US. And this is probably an underestimate, to be honest. How does it look? This was State of Oregon data years ago. How does it look by gender or by sex? And I will tell you that, we think of this as an older female disease. And as populations or people age, it does in fact become predominantly female. But you can see in the age 50 to 59 group, and this is statewide Oregon data, it's complete data for the entire population. It's about 50-50 in this age group, slightly more for males. But as you see the age groups increase by decile of life, you see predominantly higher groups of females. So that overall, it's about 60-40 or 55-45, somewhere in that in terms of percentage female to male. Why is it more common in females, particularly overall? Probably because females outlived males, number one. And number two, they may have more risk factors, potentially more exposure, more likely to go see the doctor for their chronic cough than, say, a male. So I think there's probably multifactorial as to why we see more disease in females. We did publish this a few years ago. I call them Dudemirs, but the publisher didn't like that, so they made us call him Lord Windermere or Lady Windermere's counterpart. For those of you who don't know that term, Lady Windermere is a term coined for that tall, thin, older woman who has bronchiectasis. It was coined by a pulmonologist in Portland, actually, like, I don't know, 40 years ago or something, because this was a character in an Oscar Wilde play who looked like that woman I just described, who held her cough in. She was very demure, and the idea was she didn't get her sputum out, she didn't cough, and the sputum would build up and cause bronchiectasis. And these are ideas. It is true that there is this distinct morphotype that I described. But we did this looking at men just to show that you see the same thing in men, hence Lord Windermere or Lady Windermere's counterpart. I think that's what the editor made us name the Dudemere article. But these dudes look just like their ladies. And they are skinny. And you can see in the red circle here, the male bronchiectatics and the female bronchiectatics, they tend to be skinny people with low BMIs, and they have kind of a higher percent of scoliosis, and they really look really similar. So this Lady Windermere thing, it also occurs in men, and it's really just in general a skinny, usually tall, but not always tall, but skinny, often with scoliosis. And we don't really know why those things go with bronchiectasis and go with pulmonary NTM, but they do. NTM and mortality. So years ago, I would have told you that getting pulmonary NTM doesn't shorten your life, but it actually does. And this is my buddy's work, Ted Maris up in Canada. They showed that, you know, your 5-year life expectancy is lower if you have disease. This was an adjusted hazard ratio of 1.23. We did the same thing in Oregon. We found the same thing. Your hazard ratio for dying in 5 years was higher. So, you know, overall mortality was 1 times higher. So I do now tell patients, yeah, it's mainly a quality of life issue, but it could, particularly if you don't do anything about it, it could shorten your life a few years. So what are the risk factors? I mentioned some of them: bronchiectasis, CF that leads to bronchiectasis, rheumatoid arthritis, anything that causes interstitial lung disease or bronchiectasis, alpha-1 antitrypsin deficiency, smoking, emphysema, I mentioned. Prior TB, actually worldwide, is a huge cause of bronchiectasis, and then subsequent NTM. In terms of exposure, I mean, we know people get this from the shower. We know they get it from their hot tubs, from gardening. It's probably a risk for some people. CPAP machines. I mean, you know, if you really talk to your patients about how do you clean your nebulizer out, or how do you clean your CPAP, things like that. I mean, a lot of people clean these things with tap water, which is a huge mistake because tap water has NTM. I've had a number of patients who just look like they're colonized. They keep isolating MAC, and you know, you ask them about what they're doing. It turns out they're forcing MAC into their airway every night because they clean their CPAP mask out with tap water. And you know, if you can get rid of that source, they actually stop isolating the bug. So there's no question that that can be an issue for people. I tell people not to clean their nebulizer that much, number one, because I don't think they need to, and number two, when they do, to use boiled water so that it's sterile, and use that to clean a nebulizer, their tubing out, or their CPAP mask, etc. So boiled water, I think, is a good thing in those regards. What about immunosuppression? I've spent a lot of time looking at immunosuppression. This was one of several articles that we produced, as well as others have produced, looking at the role of both systemic steroids or inhaled corticosteroids. I think when I started doing this work about 20 years ago, everybody I saw with bronchiectasis was on inhaled corticosteroids. I think there's a lot less use the last 5 years or so. I think because the word got out that, hey, these things cause infections, particularly NTM, but other infections, can be acquired pneumonia, etc. So I do see less use of it, but this was a look in Kaiser Permanente data in Northern California, where we found this dose-dependent increase in risk for pulmonary MAC associated with inhaled corticosteroid use. So I do try to get people off those therapies If they need them, i.e. they don't feel good without them, they've got too much obstructive lung disease, then, I think the benefit of being on them is enough. But if they don't get a lot of benefit from them, I do try to stop them. Then there's all these other drugs I spent my career working on in terms of a drug safety person and been involved in the development programs of a lot of these molecules or doing research trying to characterize their safety. Without giving you that whole hour talk and all the studies behind it, I can tell you I've highlighted all of in gold the drugs that we think or have been well documented to increase the risk of mycobacterial disease, both TB and NTM. The latest I would say below are JAK inhibitors that are out for rheumatoid arthritis and ANCSPON and psoriatic arthritis, et cetera, a whole host of conditions. But suffice it to say, TNF blockers are an issue. Probably the biggest issue with JAK inhibitors, those probably carry the highest risk. And then there's some risk with the B-cell depletion agents and IL-6 blockers. Abatacept, there may be a slight risk, but that tends to be a drug that we actually use if someone needs a biologic and they're not eligible for some of these others, the IL-23s or IL-17s. We tend to use abatacept because it probably is much safer, and there's data to support that, both animal model data as well as human data. It's observational, as well as some RCT data suggesting that abatacept's a safer biologic than, say, a TNF blocker when it comes to these types of infections. This was one of the first studies we did years ago looking at the risk of TNF blockade and TB and NTM in the US. And you could see in the general population, the risk of these infections was about 5 per 100,000, slightly higher for NTM. But as you looked at older individuals and then RA patients, not on TNF blockers, the risk was elevated. But if you looked to RA patients with TNF blockers, of course, the risk went up about tenfold, and it was twice as high for NTM. So again, TB, you can screen for it. You should, in the context of these therapies. NTM is a little harder to screen for, of course, and it is more common in the US. So we've been working on ways to screen for NTM and diagnose NTM. We published this a couple of years ago, looking at a commercially available assay in Japan. It's not available here. It's an IgA, anti-glycopeptidolipid core antibody. And it turns out it is expressed in patients who have pulmonary MAC. We did an evaluation in the US. This was one of only two now, I think, evaluations in the US. We played around with the cutoff value here of 0.7 and then a higher cutoff value, which is, lower cutoff value, which we found to be more sensitive. The problem with commercial recommended cutoff value 0.7 is that the sensitivity was only about 48% when looking in cases versus healthy individuals or non-cases. The specificity was quite high. We were recommending probably using a higher cutoff value to increase the sensitivity. Suffice it to say, one thing I was interested in is, do levels go down as you treat someone? And they in fact did decline. You can see these minuses here. This is the minus in their geometric mean titer. They do decline with therapy. So there is something here. It probably can be used to diagnose or screen. It probably can be used to monitor improvement, but I'm not so sure about sensitivity. It's not available here anyway, so don't worry about it. But I hope to work on this more because it could be a useful tool, particularly for screening around biologics and some of the settings of immunosuppression. What I think is prime time, and I think it will be available in 3 to 5 years. This is something we're working on with Tony Hu down in Tulane. And he and I met up at a conference we run, our NTM consortium meeting a few years ago. And we decided to start collaborating, and I'm really glad we did. He's really smart. He's like a genius. Anyway, he's part of an effort in a company that is using cell-free DNA technology to diagnose TB. In fact, just got approved for that. And we've been working together to look at it in MAC and then some other NTM. And you can see here pretty clearly in panel B here, controls, these are MAC patients. It was almost 100%, 98% sensitivity, 100% specificity. This was really fantastic. And in fact, this one of these cases that was low probably didn't even have MAC. So it's probably 100% sensitive, 100% specific. This was our preliminary evaluation. We published this in the Blue Journal, AJRCCM last year. And then I'll also show you panel B here. What was really cool is that if we follow people from the start of treatment through 6 months, we see their cell-free DNA levels go down, and they go down below eventually the level of quantification. So we do have an NIH grant right now for the next few years where we're hoping to validate this assay, to show that you can diagnose up front, which our preliminary data suggests, and that you can use it as a biomarker for disease burden as you treat someone. And probably after you finish treating them, you can use it as surveillance to see if they relapse or are reinfected, rather than doing so many CT scans over time. Okay, let's talk about treatment. That's diagnostics. Now, treatment, you don't treat everyone. You see that above. Diagnosis does not equal decision to treat. Some people have really mild disease. You may watch them for a while until they start progressing or having more symptoms, and you decide to treat them. This is somewhat of an art form. Treatment is best defined for MAC. So there we use azithromycin with rifampin and ethambutol. We add IV amikacin if they have a cavity. There is an inhaled form of amikacin, liposomal amikacin, that we use for people who aren't responding to the first-line therapy, and I'll mention that in a moment. You can dose daily. You can give it thrice weekly. I tend to like daily because I think you use lower doses, at least with the azithromycin daily. I think people tolerate it better. You will see that culture conversion to negative really varies. It's between 50 and about 85%, depending on the case series or observational study that's been published. This is what's most depressing. Within 3 years, the people that look like they've converted their culture, they've been treated adequately, within 3 years, about half of them will have positive cultures again. And I tell patients that that doesn't mean you have to be retreated, but only about half of those people end up being retreated again over time. But the bottom line is most of these people they have nodular bronchiectatic disease. It's the biofilm in the airway. It's very difficult to eradicate the bug. And then also people will get it back from the environment as well. So that's what explains that high relapse rate. I think what is most depressing is that we have this recommended therapy, and then my good friend and colleague Jen Koo and I did this a couple years ago, and we published it in CID. But you can see over here on the left of people diagnosed, and this was using Medicare data, people diagnosed with pulmonary MAC, only about half of them go on the standard therapy, azithromycin, rifampin, ethambutol. The rest are substituting one of those drugs with something else. Ethambutol is not in the regimen, or fluoroquinolones are in the regimen, blah, blah, blah. The bottom line is half the people are on the recommended therapy, and at 6 months, only half of those are still on it. And in 12 months, only half of those are still on it. And, it's recommended to treat these infections for at least 12 months after culture conversion negative, which, usually takes 14 months, sometimes 16 months, something like that. You usually see people convert their culture in the first 2 to 4 months of therapy. The bottom line from this is very few people are using or staying on the recommended regimen. And this is probably due to tolerability reasons. And that's something we have to overcome. So how are we going to overcome it? Well, we're going to develop new drugs that work better, which is what we've been doing for TB. And we're trying to now catch up in NTM. So this is the landscape. These were RCTs for pulmonary NTM 10 years ago, 2014 or 11 years ago. And you can see the slides blank. And there was absolutely nothing. And now, 10 years later, we've got a number of trials, both repurposing old compounds like clofazimine, and then we have new compounds like liposomal amikacin, epetraborole, and some of these other things. And I'm going to mention a few of these things as I go along and highlight some of the successes as well as a few of the failures. So the first thing is, and I want to thank Dave Horn and UW, because you guys were partners in this and part of our research consortium, and helped enroll patients into our PCORI-funded 2 versus 3 trial. And the 2 versus 3 trial is comparing the regular 3 antibiotics, azithromycin, ethambutol, rifampin, with just 2 of them, azithromycin and ethambutol. We dropped rifampin out of the regimen, and we wanted to study whether that made a difference. The reason we dropped it out is data like this. This is hollow fiber model data, but all these curves, and I'm colorblind, so I can't even tell you what thing is what. But I will tell you that when you look at both animal models and hollow fiber models, the rifampin doesn't seem to make really any difference in terms of the ability to prevent macrolide resistance and in terms of the kill MAC rate. So there is this idea that rifampin does nothing other than cause more toxicity. So we started this study, and we just finished enrolling it. The outcomes are culture conversion, tolerability. We enrolled about 475 people across 26 total sites. These are non-cavitary patients. They were treatment naive. I don't know the results yet, so next year I hope to be able to publish the results or give them to you. I can tell you that, from a tolerability standpoint, most people have done fine, no matter what regimen they're on. They seem to be that they're probably going to be non-inferior, but I don't know yet. Liposomal amikacin, this is a drug that we showed in phase 2 and phase 3 trials to improve the likelihood that someone who's failed to convert their culture with the standard therapy will convert their culture. And so it is approved for patients who've been on standard therapy for 6 months, have failed to convert their culture, and they have what's called quote unquote refractory disease. And that's refractory to the standard therapy. So we do use it in that context. This is now a phase 3 trial looking at it in its use right off the get-go. So this is liposomal amikacin, azithromycin, ethambutol versus placebo. That's ELC. That's placebo, azithromycin, ethambutol. And what we're seeing is if you include the liposomal amikacin right away, you see higher 6-month sputum conversions. This is 80% versus 64%. And this held up even a month later after you stop drug. So we're seeing that patients are converting more quickly, even up to a month after drug start. And I think, this was an interim analysis, the final analysis not done, but probably people feel better more quickly and they get to sputum negativity more quickly. So I think if you include it at the start, we're going to end up saying, hey, it might be worth trying at the start, and if you tolerate it, great, because it's going to shorten your overall therapy by several months at least, because you're going to reach sputum culture negative more quickly. This is something one of my patients in Bend, Oregon did. He took all his clofazimine tablets I've been giving him for months, crushed them up, and did this painting. This is all clofazimine, which, as you know, are brown little pills, and they will make you tan. And they also are kind of oily. They make great substrate for oil-based paintings, apparently. How does clofazimine work? We don't know. The mechanism of action is, we just don't know. It does modulate T cells. It actually downregulates Th1 responses, which probably doesn't help its activity against Mycobacterium, but it has these other properties that should provide the ability to kill Mycobacterium. This has been seen in hollow fiber models and in animal models, murine models, and you can see when it's added to other drugs, particularly, it seems to enhance killing. There is some observational studies showing that when you substituted clofazimine for rifampin, and you gave it alongside azithromycin and ethambutol, that maybe you had even higher rates of sputum conversion, culture conversion as compared to the regular regimen. That's 100% versus 71%. Again, it's observational. It's not an RCT, but this was enough data for us to go ahead and get a phase 2 trial funded from FDA. We just finished enrolling 102 patients. We gave them actually 200 milligrams daily, a higher dose than usual. We did that because we wanted people to get to steady state more quickly. We monitored their QT interval. We do see this QT rise. I don't have any data. I don't have any efficacy data to report yet from this trial, but this was monotherapy. We expect to see some sort of benefit, but I don't know. I can tell you from a safety standpoint, it was safe. And we showed that there was this little bump in QT intervals, but it plateaued. We didn't see anyone get into trouble with this dose, which was 200 milligrams daily for 4 months, and then we dropped him to 100 milligrams. So I think from this, we at least showed that this dose is safe to use, and how efficacious it is by itself. Stay tuned. We should know by probably August. Epetraborole, this is a very promising molecule. It has great activity in the dish as well as animal models in killing M. avium and M. abscessus. It's really something we need. It's an oral drug. We have no oral drugs for M. abscessus, which I'll get to in a second. Unfortunately, the phase 2/3 seamless design trial is currently on hold. We don't know the results. This was a refractory MAC population enrolled in the study, which is a very difficult population to treat and to really show benefit of anything. So I don't know where this is going to go, but I do know this drug works. And if the company goes out of business, maybe we can all put our money together and buy it, because I really want this drug, because I think it's going to help people. So we'll stay tuned. M. abscessus, just showing you probably a more destructive bug. But we used to always say that, but I have to say, after doing this long enough, I have so many patients with M. abscessus that behave just like MAC, slowly progressive, indolent. Sometimes you treat them, sometimes you don't. You watch them, things like that. The big difference with abscessus, and here's the epi, you can see it's about 5% of the overall NTM burden, and it's relatively flat, at least in Oregon during this 5 years, although it has drifted up slightly the last few years. The big difference with abscessus is we don't really know how to treat it, and it's basically resistant to pretty much all oral therapies, which I'll get into. So we kind of, by the guidelines, we suggested this induction phase and then maybe a suppressive phase. But to be honest, once you pull the IV therapy, none of the other drugs that you try really do anything. So I have kind of drifted to this, like, look, I'm going to watch you, and if you feel bad from your abscessus or it's destroying your lungs, we're going to treat it, and we're going to treat it aggressively with an IV-based therapy for 3 months at minimum, and then we're going to stop and see how long that holds you. Kind of like you're treating a CF exacerbation with Pseudomonas for 3 weeks, But here we're going to do 3 months. We're going to do it appropriately and aggressively and see how much benefit you get, and then stop and see how long it holds you. And for a lot of times, that's all some people need for a year or several years, and allows people then cycle back and need another treatment. We do have some really promising data. In terms of oral agents, clofazimine is the only oral agent. You have to get it from Europe, through the company and FDA, so not everyone can get this. Omadacycline is an oral agent, which I think shows great promise, but it's very difficult to get approved. If you're on Medicare, it's really impossible. And only about 15% of abscessus in the US is susceptible to a macrolide. So you usually don't have the macrolide. If you do, you're going to be a lot more successful. In terms of IV agents, you can see those listed here. My usual regimen is IV omadacycline daily, amikacin thrice weekly, and then I get clofazimine from Europe. And that's usually how I treat this. If I have a macrolide available, of course, I'll use azithromycin. And then we treat for 3 months and we go from there. Imipenem, we often use, some people use a dual beta-lactam approach, which has been shown to be successful in case series, but it's very, very difficult to take an IV 2 or 3 times a day. Open label study, I'll just show you, we got 50% of people to convert if we added the liposomal amikacin on top of their regimen. So I think that shows promise. Omadacycline, there's some soft case series data here. I was part of this effort. I mean, we showed we could use it, people tolerated it. We got like about 28-30% of people to convert their culture, but this was just an observational study. It led to me writing this protocol with Paratech, a company who has omadacycline. We wrote a phase 2 monotherapy trial where we took patients and we treated them with 300 milligrams oral omada versus placebo for 3 months. These were non-cavitary patients. And we saw phenomenal results. 56% of people converted their culture with omada alone versus 29% with placebo. So this was, again, monotherapy for 3 months. We saw no resistance occur. We saw improvements in their patient-reported outcomes as well. So, hopefully this is going to lead to a phase 3 trial. I don't have a crystal ball there, but these were phenomenal phase 2 results, and we're in the process of publishing those. Phage therapy, I've only treated one patient with Mycobacterium abscessus with a phage. The good news was we got rid of it, but now she has MAC. She probably had them both to begin with, but we got rid of the abscessus with the phage. Phages are, I think, in the future going to be really useful, but it's very hard to find phages that match up with the particular strain of abscessus or MAC that you're battling in the patient. And they really have to be matched very specifically. So this is Graham Hadfield in the picture. I mean, we work with him back east to screen isolates and very, in terms of cases that aren't responding to therapy. But this is something on the horizon. And then I'd be remiss if I didn't mention the tried and true flutter valves, hypertonic saline, just pulmonary hygiene can be very useful in these individuals in terms of both quality of life and prevention of buildup of mucus plugs, et cetera. There's no data with NTM, and we do have a phase 3 trial actually currently where we're enrolling people who are treatment naive with pulmonary MAC to see if hypertonic saline actually helps them microbiologically or from a quality of life standpoint. We're about halfway done with that trial, but my assumption is I think it does at least gives people something to do. Lastly, extra-pulmonary NTM. This is how I got into this. I was a young epidemic intelligence service officer. By the way, the Trump administration just canceled the epidemic intelligence service last week, which is phenomenal to me. It's CDC's wing of disease detectives that go out and investigate outbreaks. I was privileged to be one of those many years ago. This was the first outbreak I saw, and this was Nikki. She was a 14-year-old with these boils all over her legs. We linked it to a nail salon. That was me. I still look like that. I think. I don't know. Anyway, we went to the nail salon. We saw all these women using these Whirlpool foot baths. I reached down and I actually went underneath a woman's legs. I asked her if I could take a culture. I was from the health department. She said, sure, no problem. And I saw this hair sticking out of the little holes on this black little inlet suction screen in the basin of the Whirlpool. And lo and behold, when I took my screwdriver and popped that open, a big mat of hair, like a little tonsure, like a toupee, just floated out in the water. You can see all the biofilm behind. This was, after we took the toupee away to culture it. But, all this stuff grew Mycobacterium fortuitum. And this is, in fact, nail salon furunculosis, which was something we didn't know occurred until these machines had been produced and put into play across the country in various nail salons. And it turns out they were hard to take care of. And they would build up debris, which would then be seeded with Mycobacterium from the water. This is less of a problem today because we're cleaning and disinfecting these machines out better, but I still see cases periodically. Post-plastic surgery, pretty common or a classic setting for rapidly growing Mycobacterium, particularly colony or abscessus. This is a woman who had malar eminence implants that were laced with colony. She pussed out her cheekbones, her cheeks, 3 or 4 weeks later. We had to have them removed. She had scarring and dry eye because she also, developed abscesses that came out from her inferior conjunctiva. Anyway, bottom line is we treated her for 6 months, got all the hardware out. She did well, and she actually had a really good result. But that's just a classic infection. M. kanzassii, I didn't really talk about. It's a southern bug. This was a woman who was on rituximab and unfortunately died of disseminated M. kanzassii. But just to show you, that is something that is more common in the southern states in the US. And then colony, again, rapid growers, patients who are severely immunosuppressed, like cancer, particularly lymphoproliferative disease, can have disseminated disease. This is mediated through the GI tract. The bug escapes the GI tract, is in the blood, and it goes everywhere. Colony and abscessus would be common. Beyond our borders, Buruli ulcer or Mycobacterium ulcerans, Australia, equatorial Africa. There are some good studies the last few months. You can actually treat this with a couple months of a macrolide-based therapy. And that's been really good to see because prior to about 10 years ago, there was no known therapy. And then lastly, I'll end on this. It's kind of fun. It's called Spam's disease. And if you've ever open a can of Spam and just let it sit out in the hot sun for 5 days. This is pretty much what it looks like. This bubbly, kind of rugated, pinkish mess. And it turns out this patient was the index patient. I was consulted on him. We biopsied him. It grew Mycobacterium marinum. And he said to me, oh, yeah, everyone on my island has this. I made a few calls. We sent this team out to Satawan, which is in the Federated States of Micronesia. And it turns out we found this. We did a case control study out there and found that all the infections were linked to swimming in this bomb crater. When the Japanese took this island in World War II, they bombed it. They filled in one of these craters with some brackish water and introduced a fish called the Medica fish in order to eat up all the mosquito larvae and get rid of malaria. They did get rid of malaria, but those fish actually are well known to be colonized with Mycobacterium marinum. And it turns out the 600 and some people living on this island had been, a good chunk of them, 2/3 of them had been swimming in this island or in this bomb crater for years since World War II, and they were developing these really full body, in some cases, infections that they had called Spam's disease after how it looked. When the GIs from the U.S. retook this island, they brought a lot of spam with them, and so the islanders made this connection and named this disease Spam's disease. So I like to show it because I think it's still the only outbreak that's remnant of World War II at this point. There you go. In conclusion, NTM incidence rising everywhere. Pulmonary NTM therapies are rarely curative, and they're hard to tolerate, but we're making new drugs. I think there's some good things on the horizon. And then non-antimicrobial approaches as well are things that, phages, as well as just better clearance and hygiene, things like that for pulmonary NTM, which will prove to be useful. So I acknowledge all my friends and collaborators, and I did finish before 1. I think we have time for a few questions if you guys do that. Thanks for having me again. Appreciate it, and hope you have a good rest of the day.
And yeah, Dr. Winthrop, thank you so much for joining us. And sharing your expertise. This was an incredible lecture. We really appreciate it. There is a question in the chat, and if folks have questions, please submit them in the chat. I think we have time for a couple. From Dr. Paul Pottinger. So thank you so much for this great lecture. I wanted to ask about your own experience with double beta-lactam antibiotics as part of a regimen in treating pulmonary MDR-M abscessus. Dr. Khalid Dousa from Case Western is coming to visit our CF research group to talk about this, and would be curious to hear your experience, as it's new for us here at UW.
Yeah, hi to Paul, and appreciate your collaboration on patients and research in the past. So nice to hear from you. I don't have a lot of experience with it. I've probably pursued that route in maybe 7, 8 patients with abscessus over the last few years. My experience is it probably doesn't work any better than omadacycline or amikacin. And the problem with it is it's just unbelievably difficult to organize. I mean, nobody can really do infusions 2 or 3 times a day. It's really hard to do. So when I've had a couple particularly CF kids who are captive at home, they're fine doing infusions 2 or 3 times a day, but for regular people on the outside, they're not sitting around home all day, or they can't get qualified for home infusion. It's a very difficult strategy. So I have a lot of friends who are writing grants and really want to pursue this. I think it's probably efficacious, but I just think from a functional standpoint, particularly in adults, I don't have a lot of interest in it. Because it's just not feasible. It's just not a very feasible way to do this. So that's my answer. Does it mean I think it shouldn't be pursued? No, I think we should study it and try to see how well it works. And for some individuals, it might be a good solution. But I think just overall, it's a hard route to functionally imagine being feasible.
Thank you. And from John Clark, in patient with bronchiectasis and MAC that is treated in response to treatment, but then has recurrent exacerbations of bronchiectasis, which are not related to MAC, what are your thoughts regarding the risk and benefit of a daily macrolide to prevent exacerbations of bronchiectasis?
Yeah, that's a great question. So, in Europe, they use a lot of macrolide monotherapy and bronchiectatics. They have a lot less MAC. I think some of that's probably an artifact of doing fewer CT scans and just, some sort of diagnostic bias. But I think it's also environmental, and I think they have a lot less MAC, and a lot of my colleagues there use macrolides quite a bit. I would say here in the US, myself and my colleagues, say, for example, in the bronchiectasis registry, we're part of this National Clinical Center of Excellence that COPD designation has designated, and I don't know how many, there's like 15 or 20 of us. Anyway, the bottom line is we've looked in our registry data and whatnot, and we don't use a lot of macrolide monotherapy. And the reason is we have so much more prevalent MAC, and it's so hard to know when these people have really cleared their infection because a lot of them don't produce sputum, or it's very unreliable. You do a CT scan and you see tree and bud here and there, and you see all this mucus plugging, and it's hard to believe they got rid of their MAC. This is the patient you outlined, someone you treated for MAC before. So even those patients that I don't find it, but they're not really producing high quality sputum. Maybe they've been bronched. If they've been bronched and it's negative, I feel better about it. But even so, I mean, how many patients have I seen bronched and are negative, and then they grow it out 6 months later in a sputum or something, or 3 months later? So I would say I don't use a lot of macrolide suppressive therapy. I tend to rely on clearance and hygiene. I tend to, people who are having 2 or more exacerbations a year, I will put on inhaled antibiotics. I would say inhaled colistin is probably my go-to or my first line, but you have other options. And there is data to support the use of those drugs. Brensocatib, which is an dipeptidyl peptidase inhibitor, it dumbs down neutrophil responses. That should be approved. There's been positive phase 2 and phase 3 studies with 2 doses in each trial. That'll be approved this summer. That's going to be a really good antimicrobial approach for these type of patients. So I will move to that once it's available. And then, again, macrolides are a good option if you really feel assured that they have cleared their MAC or don't have, NTM.
Well, I think being mindful of our time, I think I'm going to end with a comment from Dr. Clark that I think sums up how we feel. So thank you so much for honoring our colleague, David Park, with your work, teaching, humor, and excellent patient care. We really appreciate you spending the time with us today. And it's a truly fascinating talk. Thank you.
Yeah,
And
thank
have
you.
a great
And
day and
honestly,
weekend, everyone.
if there's other questions, feel free to drop me an email at OHSU. Happy to answer them.
Thank you so much, Kevin.
All right, guys. Have a great
Have a nice one.
weekend.
Thank
Cheers.
you.
Bye-bye.
Bye.